بله بله بله
ترباب زين
اي دوای ام حاضر من چۆن دەستکەوێت مامە گیان
خۆ ئەوی پێشوشم هەر ناردووە لە گروپەکایە من بە ڤیدیۆ هەمووی شێرەکەم دکتۆر مەسعود هەمووی
باشە باشە ئینشاءالله باشە باشە
جۆمێری ئاساییە
باشە باشە خۆشەویستی
سەیرە نەکردووە
وەڵا ئەوەی ترنە وەڵا سەرم نەکردو
بە تاکیدی هەموویم هین کردو شێر کردو
باشە باشە
okay I will start with pediatric examination part 2 بزنم ئەمە چەندی pediatric examination part 2 library so I did finished so أما فاليرا لا بين الله ما دي شو هذا so on a base of symptomatology when you are facing a patient with congenital heart disease on a base of symptomatology if there is exertional angina mean that patient even got AS aortic stenosis pulmonary stenosis pulmonary hypertension Al-Kappa syndrome. So the exertional angina will be presented in all four conditions. There exertional syncope, when there is syncope, mean there is an obstructive kind of lesion, so like AS, PS. Cyanosis with syncope, that's happened with TOF, which is a TET spell. If there is dysphagia, mean there is a problem with the aortic arch, double aortic arch, or anomalous origin of right subclavian behind the esophagus, causing narrowing of the esophagus. So on a base of symptomatology, there will be dysphagia. If there is cardiovascular accident like ischemic attack, something with the brain, so that's with the either a cyanotic one, which present with either the abscess or thrombi or paradoxical embolization and ischemia. So that's clear. When you, Dr. Jan?
Clear. That's خوش ماما جان.
So if antenatally you want to predict which congenital heart disease you may face after labor, for example, maternal rubella, everybody knows that if it happened with the first trimester pregnancy, so it's present with congenital rubella syndrome, and part of the heart affection is either PDA, peripheral pulmonary artery stenosis, VP, or VSD, this is wrong, VSD and ASD. Maternal lupus erythematosus, it presents with a congenital heart block. So there will be congenital AV block. Maternal diabetes, especially pregestational, transposition of great artery, VSD, common atrium, cardiomyopathy. That's clear. Any questions, Dr. Jan?
No, any question, Kato. Continues.
Drugs, for example, thalidomide, usually causing tautology of Fallot, VSD, ASD, tricuspid atresia, and extra cardiac, there will be phocomelia. Lithium, they will present in the heart as an Epstein anomaly or tricuspid valve atresia and stenosis, but there will be no extra cardiac manifestations. Isotretinoin, which is the vitamin A causing VSD, alcohol causing VSD, PDA, and ASD, but extra cardiac, there will be a lot presentation like microcephaly, growth, and mental retardation, smooth philtrum, and thin upper lip. Phenytoin, which is fetal hydantoin syndrome, there will be the obstructive lesions like PS, AS, coarctation, and PDA. And there will be microcephaly, growth retardation like what we face with alcohol, short palpebral fissures, smooth philtrum, and thin upper lip. Nearly the same presentation what alcohol syndrome presents. Let's start with general one. So generally, you are looking for the weight, nutritional status, any chromosomal anomaly, color, vital signs, etc. If you go to the gender differentiation between the two kinds of congenital heart defects, you will see how the male predominate in AS, so a coarctation of aorta, transposition, hypoplastic left heart syndrome, pulmonary and tricuspid atresia, and totality of follow. But female predominate in the ASD, PDA, and Epstein anomaly. So that's the differentiation, gender differentiation. Then, if you look generally to your patient, if, for example, if you look to your patient and the patient was short stature, so terminal Noonan syndrome, Ellis van Creveld syndrome will come to your mind because all three will be associated with congenital heart defects. When you have poorly developed lower extremities, so you should put in your mind coarctation of aorta. Okay, in the head and face, that's a general look. On the head and face, for example, hypertelorism associated, or one of the features of Noonan syndrome, Turner syndrome, which associated with bicuspid aortic valve coarctation of aorta. Noonan syndrome associated with peripheral pulmonary stenosis and ASD. Multiple lentigious syndrome, which is Hockham and PS associated. Also, there's hypertelorism. Williams syndrome, which there is hypertelorism also. You will have supravalvular AS and peripheral pulmonary stenosis. For example, if you in the head and face, you look for webbing. You found a webbing. So Turner syndrome and Noonan syndrome will be one of the differential diagnoses which associated with congenital heart defects. Low set ear, like in Down syndrome, Williams syndrome, and Noonan syndrome, which usually associated with congenital heart defects. Lower posterior hairline, like in Turner and Noonan. And typical facial appearance we may found on the examination, like in Down and Noonan, which is Mongolian facies in Down and elephant facies in Williams syndrome. So these are characteristics that you look from outside to your patient, and you will get some idea which congenital heart defect maybe your patients present. Then more thoroughly with the eye. So from the outside, the eye, when you have ptosis, so mostly associated with Noonan. I mean, this ptosis got a lot of causes, but associated congenital heart disease, there will be Noonan syndrome. Or brush-filled spots, like in Down syndrome. Coloboma of the iris, which is the cat eye syndrome. So there will be tricuspid atresia, ASD, VSD, and TOF. So there will be a cyanotic kind of associated anomaly with coloboma of the iris. Premature cataract, which is the PDA associated with rubella syndrome. Internal problems with the eye, retina. So if there is a tortuous retinal artery with uterine without characteristic change of hypertensive retinopathy, usually associated with coarctation aorta. So in case of coarctation aorta, you should send for retinal examination for tortuous retinal artery anomalies. If you go to look to the mouth, in the mouth, if you have absent philtrum, so mostly associated with fetal alcohol syndrome, or you have long philtrum, so associated with Williams syndrome, and if you have bluish discoloration in the lips, mostly it's a cyanotic, which is associated with cyanotic conjunctivitis. A mucous membrane problem, like when you have a cluster of small ruby pads in the skin, in the mucous membrane of the mouth. So hereditary telangiectasia, which is associated with coarctation of aorta, so obstructive kind of the arterial diseases. Then you should look to the teeth inside the mouth for malformed teeth, like in Williams syndrome, or premature eruptive teeth, like in Ellis-Van Creveld syndrome, which usually they have ASD. Usually they have ASD. In the tongue, when you have a long protruded tongue in Down syndrome, which are always out, or so many times out, or when you have high arched palate, like in Noonan syndrome and Marfan syndrome, and cleft of the soft palate, which is associated with villocardofacial syndrome associated with VSD. So these are the findings in the face, neck, and everywhere associated anomalies. Then on the color base, then when you have a cyanosis and clubbing, so that's a cyanotic congenital heart disease. And when you have a differential cyanosis, Dr. Jan, when you have differential cyanosis, what I mean by differential cyanosis, when you have do you understand what's differential cyanosis, Dr. Zira?
What means by differential diagnosis?
Yeah, differential cyanosis. Differential cyanosis means that you have cyanosis in the lower limb without being in the upper limb. Okay, so in that case, the PDA there with severe pulmonary hypertension. So through the PDA, the blood comes from right to left. So the lower limb supply with desaturated blood through the PDA down to the aorta. So the lower part of the body will be desaturated, but the upper part will be more saturated. So that's a differential cyanosis. So you have a high sat in the upper limb, but low sat in the lower limb. So that's happened with PDA, especially in neonate, Dr. Zira, especially with the neonate. When there is a pulmonary hypertension, you will see this difference very clearly in neonatal units. The third possibility of color presentation of congenital heart disease is reverse differential cyanosis. So differential cyanosis is the upper is well saturated and lower is desaturated, okay? So this is clear. But reversed one mean the lower part of the body is well saturated, but upper part is desaturated. So what's the condition? This is happening also in the neonate. What conditions comes, when you have transposition with pulmonary hypertension, transposition, because the aorta will fed by the right side of the heart, okay? But the left side will feed the pulmonary arteries. So in that case, the left side, okay, somebody is coming in. So the left side of the heart pumped saturated blood, right? And pumped to where? To the pulmonary artery. And from pulmonary artery through the PDA down to the descending aorta. So by this, the descending aorta will be saturated, and the upper part of the body, which is supplied by the ascending aorta, which comes from the right side of the heart, will be desaturated. Clear?
Yeah. Clear.
If not clear, I can clarify more. So
that's what the
so it's very clear. Okay. So through the PDA, the saturated blood goes down. So the lower part of the body will be saturated. But the upper part of the body, because it's the blood comes from aorta, which is from the right side of the heart, so it will be desaturated, right? So also it happens in the neonatal unit. It happens in the neonatal unit. Take care of that. So in neonate, we may have all these presentations. Maybe you can see such a finding like in a month or two in your practice even. Okay, structure of the body, because most of the congenital heart defect associated with abnormality in the structure in the body. Like, for example, in when you have polydactyly, so the followings will come in your mind, like Elizabeth, which is associated with ASD, Lawrence-Moon-Biddle syndrome, which is associated with ASD again, and PS, Turner syndrome associated with bicuspid aortic valve coarctation of aorta. So all those presentations will be associated with polydactyly. So if I say polydactyly associated with coarctation of aorta, yeah, that's right. Polydactyly associated with peripheral pulmonary stenosis, that's right. Okay, so that will be the finding. If you have syndactyly, so probably you'll have Ellis-Van-Creveld syndrome, probably, so associated with ASD and peripheral pulmonary stenosis. So syndactyly may associate with peripheral pulmonary stenosis. Finger thumb. So I mean, it's the thumb will be triple phalanx. So that's fingered thumb. So it associated with hold oram, which is eventually associated with ASD. So in case of hold oram syndrome, you have ASD and finger thumb. So triple phalanx thumb. Broad thumb and toes, like Robinstein-Tabby syndrome. So it associated with PDA. So PDA associated with semian pulmonary crease. That's clear for Down syndrome and AVSD and VSD and ASD. Cubitus valgus deformity, that's Turner, and you know this. Rocker bottom feet, that's trisomy 18 and associated with VSD and PDA. So there will be structural anomalies associated with congenital heart defects. Okay, if you look here, my cursor is not clear, is not seen.
This picture, دكتور
أو كرسري سديارة ما دكتور.
بله
هذا باش بوي والله شلون كان بوي ديار به. أما بين ما. Okay, so here we have advanced clubbing, cyanosis, lips, tongue, and everywhere. So that's central cyanosis, just for clarification. Oops, sorry. So it's not so clear here, but this is a differential cyanosis. But sorry for not be very clear. So when you compare both upper and lower limb, you may see differential cyanosis. Either it's a reverse differential cyanosis or differential cyanosis. Baba, it's a seria maca. So the upper part is desaturated and lower part is saturated. So that's the reversed differential cyanosis. So when we finish with the examination of face, neck, eye, and everywhere, then we look for jugular venous pressure. You know, most of the times we are not doing JVP, right? In the cardiovascular examination. But you should be very aware of it, because when you are facing a case like a teenage, you should do it. So in a teenage, you should do it. So JVP has a significant finding in cases of congenital heart defects. For example, in titology of flu, when you have a patient aged, like become big enough, like in teenager or later on, so you may have prominent A wave, and in case of postoperative, we may have a prominent A and V wave even. So you should very aware of that. In tricuspid atresia, again, you have prominent A wave, and plus, so tricuspid atresia, pulmonary atresia with intact septum. So when you have a PS, restrictive RVOT, you will have prominent A wave. In Eisenmenger syndrome, also you have prominent and AV waves, and sometimes the V wave can become very prominent. So the A wave, A, V wave. So the V will be very peak that in Eisenmenger syndrome. In TAPVC, which is total anomalous pulmonary venous anomaly, there will be prominent V wave. So in Eisenmenger and total anomalous, mostly the V wave will be more prominent than in tricuspid atresia with A wave, because the A wave is reflecting the arterial shoot or arterial beat. So because it's already the tricuspid valve is obstructed, so it will hit the valve and reflect back to the vein. In Epstein anomaly, there will be both, because you have regurgitation and you have like a stenotic kind of lesion. So JVP is very important. And how to do it? It's easy. You position your patient, and then the center of RA is approximately 5 centimeters from sternal angle. The center of RA, right atrium, because you need to pressure the RA. So the right atrial pressure is equal to the vertical blood column plus 5 centimeter wetter, let's say. And then the if you look here, just let's put here, okay. And normal JVP is less than 8, wetter or 6. Usually, if you look to the RA, the pressure is there like 6 and 7. So if less than 8, it's acceptable. Okay. When you detect abnormalities, like in elevated JVP, in congestive heart failure, when you have tricuspid regurgitation or tricuspid stenosis, or you have constrictive pericarditis or cardiac tamponade. But falling of the JVP, usually it's a hypovolemic shock. If you are just studying some of the signs related to the jugular venous pressure, Cosmal sign. What's Cosmal sign? Paradoxical rise in inspiration. So there will be paradoxical against inspiration. So when there is inspiration, there will be rise. Usually there will be fall. Okay, or there is a failure of falling. So either during inspiration. So when you are assessing the JVP, okay, when you inspirate, the blood backs to the heart, right? So the JVP will be down. Usually, that's normal. But when it's up or fail to fall down, this is called Cosmal sign, okay? Very important. So in which condition you may find? In constrictive pericarditis, in cardiac tamponade, and when there is heart failure. So when you have a patient in the ward with a right side failure, especially for a patient with right side failure due to, for example, failed tetralogy follow. We have patients like that. So you will see the JVP is big and it cannot fall down or fail to fall down during inspiration. So usually during inspiration, it will fall down, but here it will not. That's Cosmal sign. Okay, hepatojugular reflex, when you press the liver, there will be elevation in the JVP. That's hepatojugular reflex. And it's usually seen in right heart failure and tricuspid regurgitation. There is a sign called Friedreich sign, which is a rapid fall and rise of the JVP. So the JVP will be like this, like a shoot. It's like a pulsation. So it's like what you can feel with a carotid. So you feel the JVP like what you feel the carotid, how the heart is, when the heart is beating, the JVP will be beat. So that's due to severe TR, constrictive pericarditis, and cardiac tempo, when it is very severe. So when they are severe, they will present like this. Okay? Clear, Dr. Salman, Dr.
Yes, doctor, it's clear.
Okay. Then I will go to inspection of the chest associated with cardiac problems. So when you have pericardial bulge, so the cardiac enlargement, it happens before puberty, before the growth of the chest. So when you face a patient like, for example, 15 years, 13 years, 18 years, and you have deformed chest, so it means that problem, it's a long lasting. It was before puberty. It's not a new one. Okay. Let's. Can you mute yourself, or shall I do it? Or mute? Where is it? I cannot find it. unmute يكم بقى اگر پرسیارێک تان هەبوو هینم کرد بموەستێ. Okay. Then okay. Pectus excavata and carinata. We are seeing so many times with this finding, right? With congenital heart defect. Usually ASD is causing, and usually Noonan syndrome. So both conditions causing both problems. Female hypomastia or shield chest. That's internal syndrome. There will be increased distance between the two nipples. So Harrison groups, we are seeing a lot such a finding. So with chronic dyspnea due to a large left to right shunt. So when you have a large PDA, large VSD, any large AP window, any large shunt from left to right will cause Harrison sulcus, Harrison group or Harrison sulcus finding. Heavy muscular thorax with less developmental extremity. So you see the body belt is very big, but the lower limb is small. So that happens with coarctation of aorta. So from the general look of the inspection, that's inspection rule. So there will be a lot growth on the upper part of the body and lesser growth than in the lower part. So that's a pericardial bulge with a long-standing heart disease, and sometimes during inspection you inspect the carotid pulsation. That's with hyperdynamic. Let's say it's a case of anemia, fever, etc., or AR or coarctation. So there will be a carotid pulsation beating very clearly. Then suprasternal pulsation, which happens with the AR, coarctation, and thyrotoxicosis. Epigastric pulsation, usually the pulsation in the liver due to right side failure, or aneurysm in the aorta, or tricuspid stenosis. So any problem related to the right side of the heart, causing the blood to go back to the RA and then to the liver. So the right side of the heart beats with the liver in the epigastrium. So that's due to the problems related to the right side of the heart. When you have a pulsation in the back of your patient, so mostly suspect coarctation of aorta. Okay. When you are inspecting the chest, look for these kind of incisions. So when you look for the pulsation for deformity, then I am looking for incisions. So that's the midline incision for heart surgery. You know that. Also, we have left thoracotomy scar and right thoracotomy scar. If somebody asking you wide midline sternotomy, this is for open heart surgery. Also, the left one also used for open heart surgery for doing a left BT shunt or coarctation of aorta. So left BT shunt and coarctation of aorta. Right thoracotomy scar for right BT shunt. Right BT shunt, okay? Okay, that's an inspection. That was an inspection. Then I'm going to use my hand to palpate. So when you want to palpate the pulsation, you palpate by the tip of your fingers. When you want to look for the thrill, you look by the base of metacarpals. Then when you want to look for heave, you will look for it by the ulna or the base of the hands, ulnar side of ulnar end of the hands. So that's the places you want to use your hands for. Then you are going to look for the apical impulse. So the apical impulse. So what's the definition of apical impulse? It's a lowermost, outermost point of the definite cardiac impulse. So there is a cardiac impulse. The lowermost, the more the outermost. Outermost, so the lowermost and outermost part of the pulsation and the pericardial pulsation is the apical pulse. And the age is, the age may modify it. For example, in infancy, it's a fourth intercostal space. 5 at 5 and older as 5. So that's usually. Here, the relation to midclavicular is lateral to midclavicular here in the infancy. In 5 in the midclavicular. In older than 5 is mostly medial to the midclavicular. That usually this is a normal side of pulsation. So if you want to look for it, then that you are looking for impulse here by hand, then you allocate by finger. So at first you put your whole hand over the chest, then after you fill the place, then you try to allocate it by finger. So start by all, then end up by one. Okay, clear? So if I'm looking for the apex beat, how to interpret it? Because so many times you are saying, oh, I cannot feel it, I cannot do that. So please use this algorithm or this flowchart. Then when you are looking for apex beat, then is it forceful? Ask yourself, is it forceful? No or yes? Let's go to the no part. So it's not forceful, it's usual. So you feel it just, okay? Is it S1? S1, which is this first sound. Is it S1 or not? So no or yes. How can you know? It's easy, by the pulsation. So is it S1 or S? If S1, so is it? It's a normal one. Usually it's a normal. So it's only in the position normal. That's fifth intercostal space in midclavicular line. Maybe there's displacement due to it. So that's the usual case, usual normal people. Okay. If not, if you feel this is a S1, you feel, so it's a tapping, right? Sometimes it's tapping, tick, 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 it tapping your finger. So generally it's a normal also in mitral stenosis due to loud S1, for example, because S1 is the AV valve, right? So when you have a strong AV valve, you feel it tapping your finger. Also, you can feel it when you have a hyperdynamic circulation, anemia. You can feel it. So it just tap your finger, tap, tick, 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 tapping, okay? But if it's a forceful, sometimes it's not forceful, right? Then you feel it. If you cannot feel it, so usually it's normal, or maybe positioned by different path. I mean, it's not related to the heart, or maybe the heart in the other side of the chest. Okay, that's one case. Or you feel it, then it's normal, or maybe abnormal due to, but it's just tapping your finger. It's not so forceful. It's normal intensity. But if it's forceful, so is it sustained? So it's forceful. It's very strong. Tap, tap, forceful. But is it sustained? Sustained means it's remain there. So it's hitting forcefully, but it stay there. If stay there, yes. If not stay there, no. So I will start with yes. Yes. If yes, so that's a heaving apex. Heaving, 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 and will be displaced too. Usually it's displaced, not in the position that usually it's of, and like for example hypertrophy or lower pressure or overloaded. Pressure overload, like for example hypertrophic cardiomyopathy, AS, coarctation, hypertension. All these are hypertrophy. So when you have hypertrophy, you have strong myocardium. So it will stay for a long time. It will be strong and stay. So that's heavy. But if not sustained, so when it's not stay as it, so it's forceful but comes down again. So in that case, it's a hyperdynamic circulation. It's also displaced, but it will be diffuser, more diffuse, less localized, more diffuse, and usually it's with overloaded circulation, like for example VSD, PDA, hyperdynamic, anemia, fever, etc. So anything overloading the left side of the heart, overloading by volume, not the pressure. Okay. If it's clear, I will move. If not, if you have any question, just tell me. Then that's in apex beat. So you studied the apex beat very well. Then you are going to the parasternal heave. I told you how to do it by this area. The palpable thrust, which left the palpating hand. So it will left your hand like this. So see in which condition: right ventricular hypertrophy, left atrial enlargement, palpated by ulnar aspect, as I told you, and you grade it. You're just lifting, but cannot be seen. So it lifts your hand, but you cannot see it. So that's grade 1. So if it's seen, visible, and palpable, but you see it, but very little, and lifting cannot be obliterated. But stage 3 is visible, you can see it, you can palpate it, and you cannot obliterate it. You cannot obliterate it, degrade. So that's the third one. So stage 3, that's more severe one. Thrill, you feel it by the end of the metacarpals. So there are palpable vibrations of murmur which accompany any organic murmur grade 3 and more. Very important, more grade 3 and more. Okay, so which the areas you are listening, looking, hearing things. That's the second intercostal in the right side, which is the aortic area. The second intercostal space in the left side of the chest, which is the pulmonic area. Let's go to the apex. The apex is the fifth intercostal space fifth intercostal space, mid-clavicular line, which is the mitral area, and tricuspid area is the lowest part of left sternal border. That's the left sternal border. The lowest part is the tricuspid. The area between the pulmonary area and tricuspid area is called Erb's point. And you may ask why Erb's point is there. Erb's point, you may hear subpulmonic VSD or subpulmonic obstruction. So this kind of VSD and this kind of obstruction can be more clearly seen in the Erb's point. Okay, so that's the same presentations that I did on more clear view. Then I do start with the auscultating the heart. Auscultating the heart relatively is auscultation is looking for what? You are looking for the heart sound, and you are looking for other things I will go through. But why heart sound is there? So heart sounds, the S1, which the sound 1, is due to AV closure. The S2, which is the sound 2, it's the closure of the semilunar valve, which is the pulmonary and aortic valves. The pitch, I mean, how they are strong, how the pitch of that sound will be lower in S1 and higher in S2. Usually, normally. The duration of first one is longer than the duration of second. Okay, that's usually, normally. And the point, which is the apex and mitral area, and the point is the base of the heart. Okay, base, you know what's base. Base is up, apex is down. Okay, and location in the cardiac cycle, usually at the end of the long pause, and at the S2 will be at the beginning of the long pause. Okay, I will go through the abnormalities. Please concentrate here. It's very need more concentration and more thorough looking. So if I'm go by one, this is the S1. S1 is a sound 1. Okay, the sound 1. The sound comes from where? Mitral and tricuspid valve. Okay, so the mitral valve, if I have a soft one, there will be a mitral regurgitation, because the mitral valve cannot pump a lot, so that's why it will be soft sound. Or tricuspid regurgitation, because it's also, so any regurgitation in the mitral, tricuspid, or calcification, there will be soft sound. Why? Because it cannot close very strongly to create such a big sound. Okay, so it will be soft. Okay, let's go to the other reverse of that, which is loud first sound. So a loud first sound will be something strong hitting each other, like in mitral stenosis, which is rare in children. Tricuspid stenosis is more common in children, but it's rare, but it's more common than mitral stenosis. So tricuspid stenosis, mitral stenosis, but this is very common, high output state. So many times when you face a baby, especially when they are very thin chest, thinny, you hear very loudly the first sound, and usually they are afraid from you. Usually, sorry. So 10 minutes left for me. I will finish in 10 minutes some part of the exam because so many is left. Okay, we will make it for next sessions. So a high output state is one of the common presentation in pediatric for loud S1. Okay, and common presentation. Soft S1 is MR, just to know. Splitting, splitting, that's very interesting. Splitting of S1. Usually here in S1 is very difficult if you are not experienced with, but splitting with it is more difficult. But you should be very, very, very practiced with it to understand it. So right bundle branch block, we have a lot cases like this. Right bundle branch block, we have a lot. You can practice yourself. Okay, so usually you should practice with this one. Okay, pulmonary hypertension. So when you have a pulmonary hypertension, you'll have split its first sound, and really in pulmonary hypertension you have loud second half sound and splitted second sound. I will go through the other findings of and when you have a left ventricular pressure is yes, Dr. Salmat.
Doctor, in pulmonary hypertension, you said there will be splitting of the S1. So
Yes.
Can we see that in units also?
Neonate, I am afraid not. Do you know why? Because they will tachy a lot. So when, for example, when you are ausculting a neonate, the heartbeat is between 140 to 180, right? Usually neonates like this, right?
Yes.
It's not like an adult one when you have a 60, 70, 80 beat per minute. So it's a half of that time to be elapsed when you have one cycle of the heart. So if you have two cycle against one cycle of adult, probably you will miss splitting in the small creatures. But when you are dealing with the adolescent, 10, 15, they look like adult patients. So you should elicit for such a finding. And pulmonary hypertension and right bundle branch block. I don't know left ventricular high pressure, no, but right bundle branch block, we have a lot. We have more than 600-700 tautology repaired cases. So you can hear those patients, and you can elicit first sound splitting. Okay.
Okay. Thank you, Doctor.
You are welcome. And when there is another entity which is called reverse splitting, it's very difficult to elicit it. But what happens, the splitting will be reversed. And really, personally, I cannot also still, but theoretically, there should be a reverse splitting. And really, it's not for your exam, but you should know that there is reverse splitting. And what happens when you have a right pressure high and when you have ectopic beats, so in the you may face reverse splitting because of the over distension of atria against high pressurized LV or RV. Okay. So still on the S1. So when we have this, is put it, this fact in your mind. When you have a wide splitted with loud T1 or S1 component, so T1 is loud and splitted, widely splitted. So that's Epstein anomaly, because Epstein anomaly is a problem of the tricuspid valve. You know that, okay? But here the T1 here in the let's say in the tricuspid area more clearly, because the murmurs of the right side can be here on the right, more in the lower left sternum border. I mean the tricuspid area. And absent T1, which is the tricuspid valve component of the, so because the first sound has two components, right? M1 and T1, okay? When it's splitted, but the second sound is loud, so that's Epstein anomaly. When the second sound is absent, that's tricuspidration. And we have cases like, for both, I have cases. If you want to practice your brain, I can bring both of them and we practice on that, okay? We will practice on these two conditions for sure, I'm promising. So we can hear both and we look for the first sound and we see both sounds, the T1, sorry, M1 and T1. And then if the T1 is loud, this is tricuspid regurgitation, which is the form of Stein anomaly. But when there is absence of T1, just M1, one component is there, so that's the tricuspid ratio. So it may comes with the exam, these kind of in MCQ usually they will come. Okay. I'm going to the S2 now, if time allow us. So again, we have either S2, which is the sound 2. The sound 2 either it's a soft or loud or single. If it's soft, like it happens with the AS, because you know the S2 is a component of A and P. Okay, let's say A2, P2. So when you have AS, PS, so there will be soft S2, or it's calcified. The same dog what happened with the mitral stenosis, mitral problems. But here in mitral was regurgitation, take care of that. But in the outflow is the stenosis. Okay, so when you have stenosis, you will have like in AS, PS, and calcified left ventricular outflow tract. So there will be soft S2. When you have loud S2, the loud S2, I don't know how much time left for us, but I'm not sure. Maybe 3 minutes. Loud S2, we can just finish this slide. Loud S2, either loud A2 or loud P2. If loud A2 is a systemic hypertension, if loud P2 is a pulmonary hypertension. So if loud A2, also we have other differential like aortic aneurysm, dilatation of ascending aorta. But loud P2, pulmonary hypertension, ASD, PDA, and large VSD with flow, more flow, not pulmonary hypertension, flow. So in that case, you have P2 loud. If A2 loud, it happens here. And single S2, sorry, absent A2, which is in severe AS, and in severe PS, there will be absent P2. In tautology of Fallot, you have single sound. In transposition of great artery, you have single sound, because the aorta will be anterior and pulmonary will be back here, anteroposterior, so there will be one sound here. So that will be the presentation. Thank you to be with me, friends. I'm happy to deliver the next, but really there is no time. So we will put it for next session. احتمال لم نزي كان ان شاء الله زور يعني لم تسير وجدات بس خوزقة I hope everybody here, because this is very important subject, believe me. And next slides also, I have a lot nice slides for practical sessions. Okay,
thank you so much.
You are welcome.
Thank you. That's for sure.
Okay.